Welcome to Peer2Peer, the podcast, brought to you by Rayner. Listen in as we hear from top surgeons having great conversations with their peers about hot and popular topics in ophthalmology. In this episode, host Gerd Auffarth is joined by Professor Martin Dirisamer to discuss the do's and don'ts of implanting toric IOLs. Professor Gerd Auffarth is one of the world's leading intraocular lens experts. He is a chairman of the Department of Ophthalmology, Ruprecht Karls University of Heidelberg, and the head of the David J. Appel Center for Vision Research. Professor Martin Dirisamer is a cataract surgery specialist at Dirisamer Luft Priglinger Practice in Linz, Austria. He has achieved numerous awards for various lectures and posters, and was recognised as one of the 40 most influential ophthalmologists worldwide by the Ophthalmologist magazine. Let's jump in.
Hi, I'm your host, Professor Gerd Auffarth, and today we are speaking with Professor Martin Dirisamer about implanting toric IOLs, do's and don'ts. So it's a pleasure to have you here, and let us just talk about toric IOLs. And my first question would be, how can we identify patients for toric IOLs, and what kind of measurements are important to identify these patients?
Yeah, hello from my side as well. I'm very happy for this kind of invitation. Yes, toric IOLs, I think it's a big topic and it's getting more and more important. So yeah, well, who is suitable for toric IOLs, or who needs toric IOLs? I think we have to keep in mind that I think it's approximately 30% of all the cataract patients we deal with have more than one diopter corneal astigmatism. So they are suitable for toric IOL. So first of all, I think proper measurements and examinations are mandatory to figure out which kind of astigmatism we have to deal with. So, and for toric IOLs, we have to figure out whether it's corneal astigmatism, of course. And for these, we do in daily routine different kinds of measurements, so different devices. So it's kind of a mix of different devices and technologies. So, of course, as everyone else probably do, we use an biometer, but additional, we also do topography or Scheimpflug or anterior segment OCT-based measurements. And I think it's a good advice to use different devices and also repeat measurements to get a very proper measurement of this amount of astigmatism.
So do you have a preferred method? So the other way, what do you trust more, your IOL master or your pentacam?
Neither to 100%.
Okay.
So yeah, it's a very good question, because I think there are some studies out showing that there's probably the IOL master has advantages, but there are also studies showing the pentacam shows probably the more precise measurements, because also the posterior part of the cornea is taken into account. So, well, I think it has to fit together and make sense. So if you have a measurement with the IOL master and a totally different axis in the pentacam, there is something wrong. And so either you have to repeat the measurements to another appointment. So what I usually do if the measurement does not really make sense, so again, check the patient, check the cornea, probably it's a basement membrane dystrophy or something like that. We routinely ask the patient to use artificial eye drops for 2 or 3 weeks and then come back, and then we check it again. So if you're not 100% sure that it makes sense and the axes are approximately the same axis and the amount of astigmatism, you should not go for the toric IOL.
So you mentioned membrane disease, stuff like this. So dry eye, I think it's also very important. What about contact lens wear? Do you routinely tell the patient not to wear contact lenses, or what do you do if the patient didn't know about that and comes to you and says, oh yeah, I had contact lens last weekend when I was somewhere?
Yeah, probably the most important question if you want to put in toric IOL in patient and check whether he used contact lens or not. because it's very likely. So for soft contact lens, we ask them to at least 10 days, better 2 weeks, and for hard contact lens, at least 2 weeks, better 3 weeks. And still then you could measure this kind of warpage, which some patients show. So, and again, if we are not 100% sure, just take your time, repeat the measurements, ask the patient to come back again, because a wrong calculated IOL or wrong placed IOL, toric IOL, could be very a pain for both sides.
Yeah, you mentioned that 30% have more than one diopter of astigmatism. So what would be the minimum correction you would use for toric IOL calculation? I mean, not all companies offer a whole range of lenses. Some even do customized lenses, but most of the companies have like fixed amount of toricity, like T1, 2, 3, 4, 5, whatever. So what is your approach?
So my personal approach is it depends on the axis, of course, but 1 diopter roughly is where I at least look whether this toric IOL will bring some benefit for the patient. So if it's on a steep axis, you may do the clear cornea incision on a steep axis, and probably also opposite clear cornea incision. But on the flat axis, I would go probably with 0.75, something like that. And that's a very good question, because if you look to the manufacturer, they have probably quarter diopter steps. So the question is how precise we could be with quarter diopter steps, and even there, this is not always a quarter diopter, because it's just in the range of a quarter diopter, so it could be even more or even less. So customized, of course, would be the best, but has a lot of administration and takes times and so on. So my question: do we have experience also with this quarter and half diopter steps that it might vary a little bit too much?
Yeah, usually for routine stuff, we take T1, 2, 3, 4 from the appropriate companies and look what is closest to that. Only in very selected cases, I do even customized toric approaches where it's more or less like 0.1 diopter. I have to say it depends on a lot of features. Also, if it's just a monofocal lens or if it's a multifocal lens. I would say, maybe you agree, that in multifocal or trifocal lenses, you may even go below 1 diopter or 3/4 of a diopter to make sure that they don't have astigmatism. Other with a normal monofocal lens, it may be not that big of an issue if there's a little bit more. So yes, I have experience with that, but I rarely use also the customized ones because it's not so often that it's really necessary. I really have to say that. But talking about that, what about, you just mentioned the incision location. How do you calculate your toric correction? Plus, you also go on the steep axis with the incision, or you just go from one location, and then if you use a toric lens, you just put it where it belongs to. How do you do that? The combination of incision, location, and toric correction.
Yeah, what I usually do is, if you're talking about the steep axis, I go by 12 o'clock position and try to make my clear cornea incision a steep axis. If it's not comfy for me, I go for a temporal approach, and I put it into account into the calculations of the toric calculator. And of course, this is an issue. No one really knows the surgically induced astigmatism, how much it really is in the individual case. But I think this is, at least in our hands, the results are pretty okay, and we're pretty happy so far.
Mm-hmm. And the other thing is, of course, when you put the lens in, how do you do the marking, or you're using surgical guidance systems? So that is always a big question. Can we depend on the surgical guidance system, or is the ink marking still the gold standard?
Very, very good question. I love it because we all have these fancy technologies in our Rs and this guidance system, which is super comfortable and easy in most of the cases. If you're used to this workflow and all your co-workers and employees are used and trained to that, it's super easy. And I think it's unbeatable. So it's really easy to use it. But in daily life, in reality, sometimes it's different. So it's a technical device which could cause some problems, has some issues, does not work, software update, what else? And no one knows how to fix that in the moment. And so I think you should be able to know how to do ink marking and should gain some experience and routine in this. Because the studies are not so bad with this ink marking, honestly. So they perform pretty well. So we have, depends where we do the surgery. So we have in some places we have ink marking, in some places with these guidance systems. And we do not see the big differences.
Yeah, I can really relate to that. If we think about the success of the toric lenses started with the ink marking. For more than 10 years, we only had that. I remember the first multifocal toric lens. It was a Rayner lens implanted by me in 2006. Was just made with 2 ink marks, and it was there, and it was a success. So I think it's not bad. And I had just recently an experience where I used the Callisto, and the conjunctiva were blown up almost like a balloon, and then suddenly the system couldn't recognize the vessel structure, and there was no marking anymore. So even these technical devices can be fooled here. Yeah, I fully agree. But on the other hand, I also have to say, since I use these devices, I rarely mark myself anymore, and I would say 95% it works very, very nice.
Yeah, there are colleagues, if you comment on that for a second, there are colleagues who do both. So
yeah,
they still mark and use the guidance system exactly for cases like you described. And I have a short question. What kind of marker do you prefer if you do ink marking, or when you did ink marking?
We have a pendular marker that I put in patients sitting upright, and you can make an impression. So the horizontal line is marked then.
So you prefer to mark the horizontal line and then intraoperatively?
Yeah.
Okay.
Yeah. And then intraoperatively I do the other stuff. So we have identified the patient, we have measured the cornea, we have calculated the IOL, we have marked it. Now we put the lens in. What do you think, and how do you handle the problem of IOL rotation, and what are your thoughts about current models in the market?
Yeah, I think the surgery itself, it's not the big challenge. You have to keep in mind some steps, that you remove the viscoelastic properly, of course, then do the final rotation, align the axis, and there are some differences. Of course, if you have a C-loop haptic, you could only rotate in one direction, and if you're not lucky, you have to go for almost 360 degree. In plate haptics, you could probably rotate in both directions, which could save some time sometimes. In my hands, I always had the feeling that probably plate haptics provide more stability. So this is just a personal feeling, and data does not really confirm this feeling. So do you have more experience with rotational stability in C-loop haptics or plate haptics, or what is the material about? So how important is that?
I think you touch a really sensitive point, because I think it's a combination of material, design, size of the eye, and the size of the capsular bag, and so on. So a couple of things come together, and plate haptic lenses like the Zeiss lenses, for example, are very easy to handle, and if you use them on routine basis, you get very, very nice results. I occasionally have a patient where I have the feeling the capsular bag is too big and it starts like propellering, so I'm hesitant in putting it in high myopics, a patient. The C-loop are better there, I have to say, because they're larger. But then you also have some issues with them. Some of the hydrophobic acrylic lenses are sticky and really adhere where they have to be. But if they rotate in the first couple of hours, and then you do the rotation later, you can also have a problem because they are too sticky. So I would say that most lenses which are on the market have a pretty good performance, and you always have this significant 5% of patients where you can be in trouble. And then it doesn't matter which kind of lens it is. I wouldn't really say that there's one lens which is better. I mean, we have lenses with special features. If you look at the Rayner lens, the Rayner toric lens has a closed loop haptic, which is has a specific design that prevents it from rotation and also from shrinkage when you have a capsule contraction due to fibrosis, which is quite important. Yeah. Some of the C-loop types have been improved with frosted edges so that they don't move anymore. Like J&J has improved their lens after a study showed that they have some more rotation than the Acrysov and so on. So there's always a little fine-tuning and fighting, but most of the time it more depends on you have left some viscoelastic behind it. Something happens in the first day or the first hours, and then next day you are off. It is very, very rarely that due to the design of the optic that like 5-6 weeks later you have an issue. So the most important thing I think is during the surgery and the first day.
What do you think about the approach some colleagues do, that they put in every toric IOL prior, they put a capsular tension ring? So if they use toric IOLs, they always use a capsular tension ring. What do you think about that? Does it make sense?
It doesn't really make directly sense. It gives, of course, the capsular bag a certain stability, but it has actually not really shown, only in very small sample sizes. I saw some studies where they showed some little advantages, but I've never seen a convincing study that this has an impact, really. Yeah.
Okay, we can save that money at least.
I would put an implant only in an eye if I really know it has an advantage, and not just for whatever. Maybe if you have a shaky capsular bag in a high myopic patient, it can straighten things out. It's okay, but not everyone. So it's a debatable question. So I think we've spent quite a bit of time now, but we could only touch some of this stuff. I think toric lenses is a topic we can talk for hours about, and for each topic. But I think you would agree that, let's say as a final word, toric IOLs have been generally accepted and are really a success story. And I think this is one of the most implanted special lenses that we have compared to the portfolio that is offered nowadays for our patients.
Absolutely. And my approach is, so the more complex the optics get, so multifocal, EDOF, whatever, the more is residual astigmatism the enemy number one. So, and I think this is why we should all go for toric when it really makes sense.
Very good. I think that's a great last word and summarized everything very nicely. And I thank you very much. And I also thank Rayner for giving us the opportunity to held this podcast here. Thank you very much.
Thank you so much for having me. Thank you.
Join us for the next episode of Peer2Peer, the podcast, where host Professor Gerd Auffarth will explore biometry with internationally renowned expert Dr. Nino Hernschel. For more information about this episode's topic and to read the show notes, visit the Peer2Peer hub at rayner.com/peer-to-peer. This podcast is provided for general information purposes only. The presenters' views are their own. Rayner does not endorse off-label use. Users must refer to the product labelling and instructions for use for Rayner products in all cases. Not all Rayner products are available in all countries. The full disclaimer can be found in the show notes.